Good evening, everybody. I am Dr. Liaquat Ali Gori, Senior Professor of Medicine and Head of Rheumatology at SP Medical College, Bikaner, Principal and Controller, Additional Charge Former at SP Medical College, Bikaner. Today, I shall be presenting systemic manifestations of rheumatoid arthritis. Rheumatoid arthritis can involve extra-articular organs such as lung, skin, eye, heart, renal, gastrointestinal, and nervous system. The frequency of rheumatoid arthritis is more in females, but extra-articular involvement is more common in males. Extra-articular manifestations in RA indicates severe and active disease and is associated with high mortality. This diagram showing various non-articular or say extra-articular manifestations starting from scleritis, this scleromalacia, Sjogren's syndrome, lymphadenopathy, pericarditis, bursitis, tendinitis, amyloidosis. It means to say it can involve any organ from head to toe, including skin, lungs, heart, kidney. So any organ can be involved. Is various showing pathogenesis, sign of inflammation, cartilage degradation, subchondral bone, this bone resorption. So this is the pathogenesis in short. I am not going in detail. Next, I will come to skin manifestations of rheumatoid arthritis. Rheumatoid nodules can occur up to 30% of RA patients with extra-articular manifestations involving mostly extensor surfaces and pressure areas, more common in males than females. Nodules are usually pigmented, painless, and movable. These are very useful as adjuvant in diagnosis and prognosis of disease and can be correlated with seropositivity, disease activity, and disease progression. These nodules can also occur internally, such as in the lungs and other organs. This is a diagram showing rheumatoid nodule over the right elbow and intermediate phalanx of the left hand. Other skin manifestations include sphincter hemorrhages, periungual infarct, digital gangrene, and ulcers which are painful, presenting as Raynaud's phenomena. If Raynaud phenomena appear after longer duration of disease onset, it generally shows a more severe disease course. Pulmonary edema is also common in RA. Leukocytoclastic vasculitis can also occur in some patients and can be seen as a palpable purpura. Pyoderma gangrenosum is a rare disease characterized by chronic recurrent ulceration of non-infective organ and usually associated with the RA. Pyoderma gangrenosum is considered as circumscribed necrotizing vasculitis of unknown etiology. Typically affect the lower limbs but can also be seen over the entire body. Pyoderma gangrenosum on right arm. Then we come to cardiovascular manifestations. RA patients have 2 to 5 times increased risk of developing severe and early onset cardiovascular disease with pericarditis as the most common presentation. Pericarditis occurs more commonly in male patients than in the female with severely destructive and nodular RA. The prognosis of RA patients with clinical pericarditis observed to be poor, particularly in first year of diagnosis, and survival predictors are age and cardiac involvement. The RA-associated cardiomyopathy may be considered as a result of focal non-specific diffuse necrotizing and granulomatous myocarditis. Some drugs used in treatment of RA have also been shown to be associated with cardiomyopathy, like corticosteroids and antimalarials. Arrhythmias are important cause of mortality among the RA patients and may be secondary to the ischemia, conduction abnormalities due to rheumatoid nodules, amyloidosis, or congestive heart failure. It seems likely that RA patients have an increased sympathetic activity which plays an important role in development of ventricular tachyarrhythmias. The most common valvular disease in RA is mitral valve insufficiency, which can also vary from 30 to 80%, followed by aortic valve insufficiency varying from 9 to 33%. The risk of developing congestive failure in RA is twice more than the risk of developing CHF in person without RA. And this excess cannot be explained by traditional cardiovascular risk factors and or clinical ischemic heart disease. Respiratory manifestations. Extra-articular pulmonary manifestations of RA include pleurisy, parenchymal nodules, airway disease, and interstitial involvement. Rheumatoid pulmonary vasculitis, on the other hand, is rare. Pulmonary involvement is seen more commonly in females. Males who have long-standing course of rheumatoid disease, positive rheumatoid factor, and subclinical nodules. Patients are usually asymptomatic, which is the most common presentation of lung disease in RA, and may have pulmonary nodules or interstitial disease simultaneously. The clinical manifestations and progression of pulmonary fibrosis in RA are similar to those of idiopathic pulmonary fibrosis. The most common ILD pattern in RA is usually interstitial pneumonia, bronchiolitis obliterans, organized pneumonia, the BOOP, which has been recently described in RA patients, has non-specific clinical presentations. It can be idiopathic in origin or induced by D-penicillamine or intramuscular gold compounds. Methotrexate pneumonia is not common complication of methotrexate treatments. Its clinical presentation is non-specific and diagnosis must be made after exclusion of other causes leading to pulmonary disease. Kaplan syndrome is defined as lung nodules in the dust-exposed personnel either with history of rheumatoid arthritis or develops RA after 5 to 10 years. Treatment of lung disease in RA is mostly empirical. Corticosteroids are usually given and immunosuppressive drugs are often added when pulmonary disease progresses and or steroid side effects appear. Gori this is my study in over 100 patients concluded the pulmonary manifestations are present in total 38% of cases. ILD was the pulmonary involvement, the most common manifestation, followed by pleural effusion. The risk of pulmonary involvement significantly increases with the duration of disease, advanced age, male sex, and associated comorbidity. It is a UIP pattern in RA, NSIP pattern in RA, gastrointestinal manifestations. GI disease in RA has many manifestations. The most common cause is the iatrogenic dysphagia, hepatotoxicity, bleeding, mesenteric vasculitis leading to intestinal perforation, and perforation should be considered on the differential diagnosis in patients with RA. It is more commonly seen in RA patients with high rheumatoid factor and subclinical nodules. Likewise, manifestations of associated syndromes such as Fabry and Sjogren may also occur and need to be considered. Physicians should carefully monitor patients or nurses, DMARDs, and biologicals for the occurrence of GI adverse events. Ocular manifestations. Keratoconjunctival rosacea is the most frequent finding and affects approximately 10% of patients. It frequently occurs with xerostomia in secondary Sjogren syndrome. Episcleritis is self-limiting condition occurs in less than 1% of patients with RA. Scleritis is painful inflammation of sclera, which may also occur in RA. Peripheral ulcerative keratitis is an extension of scleral inflammation that involves peripheral cornea and can also cause corneal melt. I had a study in our 100 patients that concluded that keratoconjunctival rosacea was the most common manifestation. The risk of ocular involvement significantly increases with the duration of disease, advanced age, female sex, and associated comorbidity. The relationship between the DAS28 score and the ocular complications were found to be statistically significant. It is inflamed or irritated conjunctiva. Neurological manifestations. Neurological problems are involved both in CNS and PNS, with symptoms varying from mild paresthesia to sudden death of patients. Articular inflammation compresses, and due to pressure effect, it can further invade the adjacent spinal cord, peripheral nerve, or neural tissues, which can manifest as pain and paresthesia. Disorders of the CNS include cerebral myelopathy, rheumatoid meningitis, vasculitis, rheumatoid nodule located within the CNS, and progressive multifocal leukoencephalopathy. In up to 50% of RA, the most common manifestation is cervical myelopathy, that is from arthritis of the atlantoaxial joint and subsequent erosion of the odontoid process. Stroke and autonomic dysfunction are linked with the increased disease activity. PNS involvement includes the both compressive entrapment and non-compressive neuropathies in approximately 30% of RA patients. Carpal tunnel syndrome is the most common entrapment neuropathy and is correlated with the severity of the and degree of the local synovitis. Non-compressive neuropathies are caused by small vessel vascularitis and manifest as mononeuritis multiplex, distal sensory neuropathy, and sensory-motor neuropathy. In our study, we had about diagnosis of 100 patients with rheumatoid arthritis. Both central and peripheral system were involved. Patient had increased prevalence of stroke, hemorrhage, and epilepsy. Neuropathy was found in more than 50% patients, and the pattern of the injury was axonal and hence poor recovery. Renal manifestations. Oral renal involvement is rare in RA. Meningeal glomerulonephritis is the most common histopathological finding, and the myelorosis is the most common finding among patients with nephrotic syndrome. In the absence of vasculitis, glomerulonephritis and interstitial renal disease are uncommon. Hematological manifestations. In normochromic normocytic anemia is the most common blood abnormality found in RA. The degree of anemia parallels the degree of inflammation and correlates with the levels of ESR and CRP. Thrombocytosis may also present as a marker of inflammation, but immunomediated thrombocytopenia is a rare disease. Freitas syndrome is defined as by the clinical triad of neutropenia, splenomegaly, and nodular RA, seen in less than 1% of patients. It is more common in white than other racial group. It typically occurs in the late stage of severe RA. T-cell large glandular lymphocyte leukemia may have a similar clinical presentation and often associated with RA. TLGL is characterized by chronic indolent clonal growth of LGL cells leading to neutropenia and splenomegaly. It develops early in the course of RA. Leukopenia, though uncommon, often occurs as a side effect of drug therapy. Large cohort studies have shown a 2 to 4 times increased risk of lymphoma in RA patients compared with the general population. The most common histopathologic type of lymphoma is a diffuse large B-cell lymphoma. So, symptoms, components of Freitas syndrome, as we already discussed. Next, musculoskeletal manifestations. Osteoporosis prevalence is 1.5 to 2 times more in RA patients than in the age and sex matched subjects from the general population. It is associated with increased risk of femoral neck and vertebral compression fractures. Approximately 20 to 30% of RA patients with osteoporosis die of complications caused by prolonged immobilization and postoperative complications following fractures like DVT and stroke. In addition to disease duration and activity, fracture risk is strongly associated with glucocorticoid therapy, immobility, a low BMI, sarcopenia, and opioid intake. Myopathy and myositis, which have been attributed to active disease, reduce lean body mass, that is sarcopenia, increase total body fat mass, and immobilization. In addition to chronic inflammation, muscle weakness commonly occurs due to pharmacotherapies such as glucocorticoids, hydroxychloroquine, and lipid-lowering agents. In our study, over 360 RA patients concluded the patients of rheumatoid arthritis, especially the advanced age, female gender, longer duration disease, patients not taking treatment, presence of deformity, high BMI, high ESR, high rate of anti-CCP, antibodies should be screened for osteoporosis using DEXA, hence helps in improving morbidity and quality of life. This is osteoporotic bones in RA. Rheumatoid arthritis in the foot showing various abnormalities. Conclusion. RA is an autoimmune condition which involves joints and extra-articular system. Risk factors for both are severity of inflammation, duration of disease, seropositivity, rheumatoid factor, anti-CCP, smoking, and male sex. Patients of RA with systemic involvement and complications should be treated promptly and should be monitored regularly to decrease the risk of mortality. Note the symptoms: stiffness, swelling, and squeezing. These are various symptoms of RA. So, the take home message: with proper treatment and a disciplined lifestyle, you can get rid of rheumatoid arthritis. Time is crucial element for rheumatoid arthritis patients. Thank you for your kind attention.